in our opinion, it is certainly true that the iGel introduction has represented a major step forwards. In fact, we all know, or we all recognize the major improvement brought by the introduction of the supraglottic airway devices. But those devices so far had some limitation, mainly related to their average degree of stability in the mouth of the patient. In fact, with the iGel, we could overcome these limitations. In fact, in our department, we tried to switch between the usual intubation of the patient towards a less invasive control of the airway during surgical procedures. And in this regard, in fact, we tried to use something that may allow us to, in fact, rotate the patient in the lateral position in order to be able to perform a caudal anesthesia on the top of the general anesthesia for the sake of postoperative pain control. In this situation, it has been very useful to have a very stable, airway control device in the mouth of the patient, allowing us to avoid any displacement of the tube during this rotation of the patient. And the iGel device proved very useful in this situation. As far as learning curve is concerned in the pediatric patient, we really didn't encounter any problems. In fact, at the first attempt, all the anesthesiologists who tried the iGel in the pediatric version were successful. In fact, not all. The rate of success was 80% at the first attempt, and the rate of success was 100% with 2 attempts. So, in fact, no real difficulty in the learning curve could be seen with the iGel device. As far as the quality of ventilation is concerned, we checked, of course, the saturation, and we didn't observe any desaturation episodes during the short series which has been published in 2009. We also didn't see any major problem associated with leaks. The maximal pressure, the leak pressure in those patients was 25 centimeters of water, which is far above the requested level of pressure needed to ventilate those patients. So the ventilation was very adequate. The main advantage we saw is related to specific issues in pediatric anesthesia. And again, we could, in pediatric patients, in fact, avoid intubation in 2/3 of the cases according to the usual protocol in our institution. So during those cases, we just could perform ventilation, avoiding all the problems related to intubation in the pediatric patient. And as you know, a pediatric patient is very prone to experience laryngospasm, laryngeal reflex reactions upon intubation, but also upon extubation at the end of the procedure. So certainly avoiding intubation represents a major step forward in the management of the pediatric patients. The iGel device was very well received among the anesthesiologist population here in our pediatric anesthesia department. And the satisfaction rate among the practitioner was more than 4.5 over a scale of 5. So, it was very well received, and people are very anxious to get it, for the usual clinical practice.